So excellent. So
Thank you.
I'll just formally introduce you. So Elvis, our guru physiologist from Nigeria, is going to do a talk tonight on asystole. So this is kind of our new and improved, well, summer version of these talks. As some of you probably know, we're moving to fortnightly catch-ups just over the summer period, just while everyone's out having holidays and enjoying the weather. So we'll reconvene hopefully probably after summer to maybe fortnightly to weekly, but we'll see how we get on. But we'll certainly update you as time goes on. But in the meantime, over to you, Elvis, for your talk, mate.
All right. Thank you, Gerard. Good day, everyone. My name is Elvis Osobaye. Currently in Nigeria, cardiac physiologist. And I'll be talking tonight on asystole. So here's my outline. And this is what asystole looks like. Asystole is actually referred to as a flat line, representing the cessation of electrical and mechanical activity of the heart. Asystole typically occurs as a deterioration of the duration of initial non-perfusing ventricular rhythms, like ventricular fibrillation, pulseless VTAC, pulseless electrical activity. So more or less like this is what the flat line looks like. This is what flat line looks like. We'll get to that anyway. Let's just keep going. So asystole represents the terminal rhythm of cardiac arrest. The prognosis has a poor prognosis. Cardiac arrest, for instance, has to do with rhythms that are not favorable to the heart. That's like VTAC, VF, that do not allow the heart to contract. There is no cardiac output during such rhythms. Yeah, so or so asystole represents the terminal rhythm of such episodes. So it has poor prognosis. About 10% survive to admission, 0 to 2% to discharge. Most patients who come down asystole eventually pass on. Termination of resuscitation effort is considered at this point. Maybe patient had been in beta or some form of cardiac arrest and kept on the prognosis kept on going bad up to the point of asystole. So at that point, termination of resuscitation is usually considered at that point because so the etiology of asystole is caused by it's common in cardiac arrest. So the causes are quite wide and could be due to decompensation of prolonged VFib or defibrillation of VT or VFib and any other cause that could lead to cardiac arrest. Especially when when the cardiac arrest is not promptly treated, it could degrade to asystole. The pathophysiology of asystole is it results from the primary and secondary. Yeah, so the intrinsic electrical system of the heart. If there's a failure of the intrinsic electrical system of the heart or an extracardiac cause leading to no electrical activity as well as mechanical activity, that's the pathophysiology. And then the extracardiac causes have been summarized into the H and the T's. So primary asystole occurs when the electrical system of the heart intrinsically fails to generate a ventricular.
To go.
Okay, so the pathophysiology, primary asystole occurs when the electrical system of the heart intrinsically fails to generate a ventricular depolarization. And this could be due to ischemia or degeneration of the SA node, the AV, and the AV conduction system. So primary systole as well, it's usually preceded by bradyarrhythmias due to either sinus node block or arrest, or complete heart block, or both. While the secondary systole occurs when factors outside the electrical conduction system of the heart results in failure to generate any electrical depolarization. And there's this other part of it, the reflex bradyasystole, can be due to either of these causes. Well, as they say, sudden death is unlikely to occur in this situation. However, the possibility exists if a systole were to persist. So asystole usually presents, depending on, sorry, I used the terminology that asystole. I would have taken that out. So it depends on what, if it's maybe sometimes weakness. I've seen patients who became bradycardic and then gradually they degraded into asystole. So such patients might come up with lightheadedness or syncope and eventually become unresponsive, maybe develop gasping or agonal breathing or no breathing at all, of course, and no peripheral pulses, carotid, brachial, femoral, no peripheral pulses palpable, no detectable heart sounds. And then on the ECG, particularly on two perpendicular leads, we'll find a flat line on the ECG screen. So it's asystole is usually evaluated on, cardiac monitoring as an isoelectric flat line. There's no P wave, there's no QRS complex, there's no T wave. That's asystole. No activity at all. The atrium is silent, the ventricle is silent. No atrial activity, no ventricular activity, no depolarization, no repolarization. So just an isoelectric flat line. And it's usually confirmed when a flat line reading is observed in two perpendicular ECG leads. And this is very important because the leads could be dislodged, or perhaps not having good contact with the patient, or possibly the connections are not very intact. And so the ECG monitor would just be showing you a flat line because it's not seeing anything. It's even possible the ECG is disconnected from the monitor. So you want to make sure of all of this to, of course, and well, patient will definitely be symptomatic, but whichever way, it's good to be sure. And this also helps to rule out VF. Some VF can be very, very fine. And if you don't look at it well from all the leads, you might think it's just asystole, whereas it's a very fine VF. So immediate investigations will be ABG, potassium levels, bedside echo, depending on the likely etiology. Bedside, in case of suspected tamponade, you want to do bedside echo to rule out tamponade. And if there is tamponade, quickly do some pericardiocentesis to take it off. That might help bring back the patient. So, and other reversible causes. So here the ACLS, AHA ACLS team has helped to, make an acronym for the reversible causes, the H and the T's, and we have them there. So once we have a graph on each, if this or if any of this is present, you want to identify them and treat them immediately. And whichever way, I'm not sure this chart is very visible, but irrespective of the level of care, minimal compression interruption is always advised. As against trying to give airway, it's better you don't even you're always, doing the CPR, the compression. It's prioritized over briefing. But if all of that can be done as according to the guidelines, then that will be perfect. So, yeah, I think this mostly just an overview anyway. This is mostly for the doctors. So in asystole, electrical defibrillation is not advised for asystole because asystole is a non-shockable reading. And looking at what we've talked about, the etiology, it could be as a result of degeneration of the SA node or ischemia in the SA node, and perhaps the AV node. So defibrillation may just rule out the possibility of recovering a reading from the heart, but most likely from the sinus, or even if it's the maybe that's ventricular, but it completely knocks everything out because the pacemaker, the SA node, for instance, is already defective. Then giving a defibrillation over that, it's completely fruitless anyway. So it's not advisable to give a shock on a systole. A CPR is advised, and look out for possible reversible causes, and maybe treat. If there's thrombosis, you want to rush and take the patient to the cath lab and get rid of the thrombus and restore, revascularize the artery, and that could also help to increase the chance of the patient recovering or returning to spontaneous circulation. So prevention, asystole can be prevented or may be prevented by appropriate use of permanent pacemakers in patients who have high-grade AV block or sinus arrest. And then for secondary asystole, early recognition and treatment of reversible causes will go a long way to prevent the occurrence of asystole. Pardon me, I didn't have, I wished I had, well, I wanted to include a case, but for time's sake, I couldn't, but I'll just talk over it. I remember sometime maybe 2018, I myself and Dr. Dafe, we had this elderly woman who was referred to him from, I think, somewhere in the East. And they managed to bring her down to, then I was doing biopsy then. So this elderly lady, we've gotten her into the theater, and it was just so favorable, God so kind. Well, she had complete heart block, and the heart rate was in the 20s or below. And as soon as Dr. Daffy gained access into the saphenous vein, the subclavian vein, pardon me, she went asystole. That was really very dry. I know he would recall that woman. So at that point, of course, they've done the needful, but now at the point of implanting the permanent pacemaker, the patient went down. Then things were not as good as they were now. We're just still starting up and building up the interventional services at that level. So we didn't have the luxury of temporary pacing then. And so we had to just go straight to permanent pacing without backup temporary pacing. So at that point, and I know this might be helpful for some other persons who are possibly within those areas of the country where certain devices and equipment are yet to be made available to them. So like temporary pacing, I know Pace for Life has done a lot to see how to help bring in some temporary pacemakers and leads to help in situations like this. So what as soon as we detected that, it was just myself, himself, and one of his scrub nurse. So I started doing CPR while he was going in with the lead, and God on our side, we got the lead into the ventricle so quickly. And as soon as we connected to the programmer, we started pacing. There was capture confirmed on peripheral pulses. And just like that, after a while, she regained consciousness. And wow, it was a hell of a case, though. So it's important to make a referral, depending maybe for physicians, make a referral for permanent pacemaker as soon as the patient is in complete heart block, symptomatic, as fast as possible. Yeah, so that's just needed to mention that to buttress the point here. Prognosis, it depends. It depends on the etiology of the asystolic reading, the timing of intervention. Like in the woman, the case study I just mentioned, if we were not timely, she probably would have passed on. And I think the last time I spoke with him about her, he told me she was still alive. That's been some years. I think that should be 2018. Yes, 2018. So it goes a long way how whatever the etiology, the timing of intervention, CPR, success or failure of advance. So all of these would determine the prognosis for asystole. And these are complications, permanent neurologic impairment, which usually result from lack of perfusion and oxygenation to the brain and the neurons generally. So they are very sensitive to no oxygen, to hypoxia. So, and other complications from maybe CPR or invasive procedures in attempts to reverse reversible causes, and then unfortunately death. So I would just say a few more things about asystole in pacemaker patients. Well, technology has gone far to help to reduce this incident, but it's good to talk about it, emphasize it, and possibly someone might benefit from it. Causes like oversensing in patients who are dependent, complete heart block patients mostly are likely going to be dependent on their pacemaker because the ventricles will eventually be 100% paced. So, and most of them will likely be dependent on it. So if for any reason there is oversensing, maybe noise due to noise, electromagnetic interference, or the lead was programmed too sensitive, which is also unlikely, programmed too sensitive, it would, oversensing generally means no pacing or under pacing rather. So the patient might not be adequately paced at those intervals. And if it's a chronic situation or a permanent situation, that patient, if dependent, may likely go into asystole despite having a pacemaker. So, and then also, so troubleshooting, if hopefully the patient has some backup reading, troubleshooting will require maybe checking the polarity, the sense polarity, if it's unipolar or if it's bipolar. In unipolar leads, unipolar sense polarity, it's usually susceptible to oversensing because it's like a far-field channel interference from the myocardium and all of that. But bipolar is preferable, and current technology gives us that opportunity to go ahead straight up to bipolar. And if the lead was programmed too sensitive, you can adjust the sensitivity so that it will not sense noise or some background, well, perhaps even myocardial potentials, myopotentials, or whatever the source of noise might be, and think it's an electrical activity, intrinsic electrical activity of the heart, and withhold pacing. So MRI scan, yes, that is also an avenue. Well, but like I mentioned, technology has really helped to reduce this occurrence in pacemaker patients. MRI, most patients who would have their device would at some point might need an MRI to rule out something. And so even if it's not MRI compatible, they can still do the MRI depending on maybe the location, the type of machine, the type of MRI scan machine, and yes, and that may help. And if it is really the risk, the risk outweighs the benefit outweighs the risk for especially those who are not MRI compatible, their device not MRI compatible, but they still have to go, fine, can take that. I know some centers, there are publications that say it doesn't really matter whether they've done for MRI patient and MRI and non-MRI devices, and outcomes have been good. So basically what you do then is to program to asynchronous mode and step up the lower rate, the lower rate or the base rate, so as to override whatever the baseline of the patient is. And that would and also I think yes, the what's it called, the output pulse. So some devices already have that. It's just a few clicks and some adjustments and you're good to go. So that would help because MRI tends to heat up the device and could cause some damage to the system, or that could affect sensing and or maybe capture. So if the patient is dependent, especially for the dependent patients, they are really the ones who are prone to susceptible to developing asystole if their device develops some of these issues. Loss of capture is also another one, and that might be due to lead dislodgement or lead displacement, or insulation damage, or lead fracture. So it's important to to advise a patient for follow-up, especially immediately after implant. You want to do a quick follow-up and ensure that their leads are well in position and parameters are good. Another point is for noise. Some patients might just need to educate them if maybe they walk or they live in areas where there's a lot of electromagnetic interference. They might just need to, or they walk into an environment and they feel symptomatic, just to educate them to step out from that place, and that will just help their devices to revert to normal function. So, okay, yes. Then battery change, device upgrade, that's another point where, although if you have risk of infection, say increases with use of temporary, but well, it depends anyway. But if you want to do a battery change, while doing a battery change as a physiologist, you want to keep your eyes on the ECG to ensure to look out for asystole, especially for dependent patient, whether it's CRT, or pacemakers. You want to look out for that. So yes, you want to look out for that, and also primarily do your check before the device change to confirm the patient has an intrinsic rhythm. And if not, so that would help to plan the strategy for adjusting, for changing the battery or upgrading the battery, whichever the case. So I think, okay, I unfortunately, I just wanted to give a picture of what oversensing, this is not complete heart block, by the way. P waves are there, but just an idea of what oversensing would cause in devices. As you see, the device some sort of did not pace following. I don't have a pen here too. Sorry. Well, you could see the pauses in between. The device in this case what should have paced in following the atrial depolarization, but perhaps there is some oversensing, most likely of maybe there's oversensing. I'm not sure. I can't really pinpoint to which direction now, but this shows some level of oversensing because we cannot find, it's not pacing. Whereas later you see, I think there's a noise on V4, V5, V6. So it probably thought that was a ventricular activity and then did not deliver a ventricular pacing. So I just brought this up for just an example. It's not a perfect example though, but just to give an idea of what oversensing. So imagine if this patient was dependent and for some reason the lead is sensing something else as ventricular activity, we probably would just see a flat line going all through. But that is not a perfect example of asystole because the P waves are there, but it's sort of like ventricular asystole, kind of. So it's just a way of, we're just trying to, use, I don't know the perfect word to use, but just trying to borrow an idea from asystole and interpose it into what it will look like, especially for dependent patients in complete heart block, if their ventricular leads becomes maybe, or something happens to the ventricular lead, or the programming on the ventricular side is not proper, what may likely occur. So I think that will be all here, my references. Thank you very much.
Fantastic. That's great, Elvis. Thanks very much.
Yeah,
It might just be worth, yeah, it was good, man. It might just be worth pointing out, if you go back to that ECG, I think what's actually going on there is, it's hard to tell, but because there are P waves and they're not followed by a QRS, but if you look on V4, V5, V6, there's actually a ventricular spike there. So I think the ventriculars tried to actually pace, but it's probably maybe it could be loss of output on the ventricular lead, as opposed to oversensing, because there's if there was no pacing spike, then you could probably argue that it was oversensing. But I think given that there's a P wave followed by a pacing spike, it would suggest to me that that's probably loss of capture on the ventricular channel.
Sure. Yeah, you're correct. Like I said, it's not really a perfect example. I just brought it up.
Yeah, no, exactly,
because of the fourth beat, where there's no pacing spike in there, but there's an obvious P wave, and nothing is going on there.
Yeah, exactly. And I think it's and just to touch on, especially when you are doing box changes and things like that on patients with complete heart block, as you're saying, doing a pre-op check is very important, especially if they're programmed in unipolar. Because if they're programmed unipolar, then as soon as you take that pacemaker out of the chest, then you're going to lose capture. So it's important that you make sure every patient that you do a box change on who are dependent, just make sure that their leads are actually programmed in bipolar. Is always a good tip.
It's not too much in it.
Sure.
I think that's a really good point, Jared. I think
Yeah,
I think we got some background noise. Just 1 second.
Yeah. Well, thanks.
I think there we go. Okay. No, that's a really good point, Jared. I think one of the things I kind of threw this together, Elvis, while you're giving your chat. I don't know. Can you all see my screen now?
Yes, mate.
Okay, perfect. Yeah, so I think one of the things to, as you pointed out with unipolar and box changes, is just to be aware of the patient's underlying condition when you're about to do a gen change, and if there are dependent, that's when you consider using like a temporary pacer or setting the device asynchronous, and then also us being aware of the polarity. So as soon as that device comes out, you're going to lose capture. So you want to make sure, I don't know if you ever use it like soaking in a wet towel and putting on the chest technique at high output. Jared, have you ever had that?
No, I haven't heard of that one, mate.
I've heard of
No.
physicians talking about it, or even touching
Right.
it to like the metal instrument within the pocket, the can
Sure.
itself, and you'll be able to maintain capture. But I think it's something to be, I don't think it's the best solution. It's always better to have a temporary pacer if you can, or have very quick hands, I guess, or, put the device in and out of the pocket for unipolar. But unipolar can also be a good solution when you're trying to capture. So I think you gave a good anecdotal example, Elvis, about a patient, being asystole on the table. We've had examples of that where the patient goes asystolic while you're trying to put in a lead, especially in a patient with a left bundle, and you accidentally knock the right bundle out. And I kind of gave this little diagram here. I don't know if you can see my mouse, but if the
Yeah.
right bundle isn't functioning, or sorry, if the left bundle isn't functioning at all, and you're fishing around in there with a lead and you hit the right bundle, you could knock out their entire ventricular conduction system, which does happen. And it's not ideal. So in cases like that, you can be ready to actually go unipolar on the lead itself with one of the wires hooked to the pocket. It's sometimes easier to be unipolar than bipolar. If you're having trouble fiddling with the getting the clamps on the ring electrode, just attach it to the pocket and go high output, and you will capture. And that also makes it a little easier switching the lead back and forth when you're plugging into a can as well. So just considerations.
Yeah, no, very good points.
So you mentioned, for complete heart block patients, one thing you can always keep in mind too, if you're doing a CRT gen change, if a patient has an LV lead, you can always pace from the LV lead as long as it has a bipolar vector set and it's not set to go to the RV lead. So that's always a consideration if you have a dependent patient, is leave it on high output, set the device asynchronous, and then just switch over. You'll have some competitive pacing between the new device and the old device, but you'll never lose a beat essentially. So just things to keep in mind there. You had talked about loss of capture. Sorry, I'm running through this because I'm in rural Kansas and I'm going to lose signal soon. But you had talked about, Elvis, loss of capture. So I just wanted to show you some pictures I found on the internet of loss of capture here. So you can see, this isn't actually, sorry. Obviously I typed this up quick. This is actually ventricular oversensing. In this sense, you can see the device has a VS and there's no actual ventricular evoked response here or anything going on. So that indicates that you're oversensing, causing inhibition. And Jared, sorry, I'll let you take point. I just kind of put this together.
Yeah, we're kind of losing you a bit there, buddy. But
Perfect.
But no, that's really some good points there, especially with the box change. It is just kind of preempting of things, and using that LV lead as almost like a temporary wire as you exchange the RV and the atrial lead over to the new system, and then make sure you're capturing from the RV lead on the new system before taking out the LV lead on the old system. And it's just playing around with things, with ideas like that is always going to be very helpful. But no, that was some really good tips. And as AJ was saying, if you're putting in a CRT device or even just a normal pacemaker, then with a patient with left bundle, then it is important to understand that when you are fiddling around in that right ventricle, that you are at risk of knocking out the right bundle. So again, just be aware of that and just be prepared. Again, if you're spoiled like we are over here, sometimes we can obviously put some defib pads on patients as well. So, and despite you not being able to shock, so to speak, asystole, you can definitely pace through the defib pads. So if your systems out there in Nigeria allow you to do that, then be sure to always use that as a bridging. I know it's not pleasant for patients, but it may be the difference between life and death sometimes. So maybe pacing through the defib pads at a slow rate, just maybe enough to give them some output that they need to get them going. Maybe the asystole may resolve itself, maybe with some drugs it might help, but it's certainly something worth noting. The other thing I like to do is with asystole as well is I see asystole as kind of this umbrella, but underneath there's there's varying reasons for this asystole. So I think in terminology, it's always important that I personally always either describe it as P wave asystole, meaning that there are P waves present, but there's no ventricular escape rhythm. So you know that the issue is probably at the AV node as opposed to the sinus node. Or do you have actually sinus arrest with ventricular standstill, in that you basically do have this kind of flat line, so where it's probably suggestive. If you're there, AJ, if you don't mind muting, please, mate, that'd be great. So just describing it so that if it is sinus arrest, then you know that the issue is probably higher up, and maybe the sinoatrial node is causing the issue, not necessarily the AV node. So it's just nice to have a bit of an understanding of kind of what you're going into, because, you know, and as you said, the primary causes can sometimes be drug toxicity. I've seen patients before where they're businessmen and they're putting on their ties every morning and they keep collapsing. I'm wondering why. But they've got carotid sinus sensitivity, so it might just be their neck ties a little bit tight, putting pressure on the carotid sinus, and they keep collapsing. So just having to listen to your patient and understanding their causes, their symptoms is, again, a lot of these asystole events outside the hospital can be reversible, not necessarily need a pacemaker for everyone, but and maybe reducing drugs, again, you know, understanding the carotid sinus massage and things like that. So that was just a couple of take-home points that I just wanted to add to your talk there, Elvis.
Thank you, Jared.
Yeah, thank you.
Really
Elvis or
appreciate it.
Jared, there was something in the chat. Do one of you mind
There was,
addressing that as
yeah.
well?
Yes, I just saw that. So I think, Elvis, it might be one for you to answer. I think it was a question about what are the limitations to using temporary.
Sorry, I didn't hear you.
Can you hear me?
Yes, I can hear you.
Oh, great. Yeah, I think this was maybe a question for you to answer. There was a question just regarding the limitations to using routine temporary venous pacemakers in high-risk patients, especially in Nigeria. I assume it's just the availability of equipment is the biggest limiting factor.
Yes, that's a major one. That's a major one. And some persons might prefer to just go straight up to a permanent pacing just to reduce the chances of infection, especially when it's available.
Yeah, exactly. I mean, temporary pacing is very, in the right center. If you're lucky enough, again, to have the right equipment, then it obviously can get you out of a tricky situation. But I mean, it's not very cost effective. And I think AJ's shown a nice demonstration here on his picture. Is that the picture on the right there is actually using a pace, especially if you don't think it's a permanent issue. If the complete heart block might be just a transient thing, maybe they're post surgery or something like that, and they're going a bit bradycardic or whatever it may be, then just putting in an actual permanent lead transvenously and connecting it to a box could be a way of getting around that as well. I know, again, it's not a very cost-effective way of doing things, but again, it may be the difference between saving the patient and not.
Sure. Obviously.
There we go. I don't think it's ever a bad idea either to keep a extra device or so just as a temporary pacer, right? No, not everyone has those pacer boxes, and in some ways, just having just a pacemaker that we have previously extracted, ready to go, is a good option. Lots of hospitals in the Northeast do that. Just keep a temporary pacer kit ready, and we're happy to help furnish that. You know, a pacemaker with a couple years of battery life. Yep. Can't hear me?
Yeah, loud and clear, mate.
Okay, perfect. Yeah. So I would just say keep that in mind. Is just always have an extra pacemaker ready to go, and you could just put it externally.
AJ, you're quite audible.
Gotcha. I'll post it in the chat then.
Okay.
Fantastic. But yeah, no, I think what AJ's saying is just having an old temporary box that may be one that you've extracted, and if you can somehow clean it up, it doesn't necessarily have to be sterile. You can put it in a bag or something, but just something that you can connect a lead to that's, again, just going to help use it as a bridging for the patient. It just allows that patient to get that lead in and connect it to something to keep them going, as opposed to feeling like you have to rush in and put a dual chamber system in, and then 2 days later the patient gets their rhythm back. So they are good. Like I keep saying, bridging. If you think the heart block or whatever it is that they're having is transient, then maybe this is a technique that you could be used. Is there any questions from the group?
Yeah, so can I just make some contribution? AJ and Gerard and Elvis, thank you very much. Great presentation.
You did
Yes,
well.
sir.
Thank you, sir.
Yes, sir. So there is the case that Elvis referred to. Yeah, we did that case 2018. The patient came in with bradycardia. As at the time we were using a CM. I think, yeah, we are using a CM, and there was no temporary pacemaker available at that very point. So the heart rate then was between 15, 16, and we said, okay, let's quickly take the case, and we got an access very fast. Then as we're trying to take in the leads, the patient just went into flat line. So it's very common with people with that very low degree of heart blocks when the heart rate drops down to around 15 or below. So as Evie said, God was on our side, and he started CPR. As he started the CPR, quickly I pushed the lead in, and we got it screwed to the apex, and the pacing starts, and the patient was jacked back to life. So that is another one case. Then this last mission we went for in Enugu, we had a case. This patient, that was 2013. The patient had a pacemaker 2013, and it was a single chamber pacemaker, a St. Jude single chamber pacemaker. So we needed to upgrade the pacemaker, and also the half-life too. The battery half-life has also gone that very low. So two things: we want to change it to a dual chamber pacemaker. We still confirm that even though the patient has been on the single chamber pacemaker for that number of years, the sinus rate is still there, just that the patient had a complete heart block, and the available thing then for them was a single chamber, and that has to keep the patient alive till when we saw that patient a few days back. So what are we going to do? We wanted to upgrade it to a dual chamber pacemaker. So myself, Dr. Seko, Dr. Mbadiwe, so we sat down and said, okay, what we are going to do is, one, we don't need to use so many gadgets. We are going to introduce the atrial leads, the right atrial leads. So that right atrial leads, the first thing we did was that we prepared the patient and dissected and exposed the battery to be changed, and that battery was still pacing. Then we took an access. So when we had the access, the next thing was that we introduced the 52 leads, 52 centimeter leads. So that 52 centimeter lead, we use it for two purposes. One, we took it down to the ventricle and screw it to the mid septum. And after we screw it to the mid septum, we tested the parameters, and they were all fine. So we connected that lead to the pacing cable, and we started pacing from the programmer. So when we did that, the patient is already pacing from the programmer. So we unscrew the ventricular lead that was attached to the old battery. So we unscrew it and change it to the new battery, connected it to the ventricular head of the new battery. Then after that, then we decrease the pacing, the lower rate pacing output until the programmer is now reading sensing. In other words, the new battery that was brought in was already pacing at 60. So we decrease the pacing output of that from the programmer to lower than 50, and it's now reading sensing. So as at that point, we are very sure that this patient we have switched the pacing from one point to the other point. So we took off the pacing from the programmer and the pacing from the new generator continue. Then we unscrew that 52 lead from the septum and pull it back into the right atrium and screw it to the atrium. Then tested all our parameters and they were fine. Then we connected and closed back. So there was no fraction of second of asystole in this patient. So you see that techniques can help us in those of us who are pacing cardiologists in the developing countries, especially if you are in an environment where you are using a CM, because a lot of cardiothoracic surgeon and pacing cardiology does this pacing in many hospitals with a CM without the need of a cath lab. You don't need a cath lab to do a pacemaker. So these tips can help in minimizing the number of things that you are going to use to take one case and also take that case very perfectly without any problem. So we felt like sharing it. Then the other thing is this. The other thing that we also need to share in this case is this. When you are also doing a CROT, it's also advisable, I think AJ mentioned it, that you should put in your right ventricular lead first. There are many reasons why you do that. One, putting that lead first tells you where the tricuspid valve is. You'll be able to figure out exactly where the tricuspid valve is, and also figure out just above, close to the tricuspid valve, you have the coronary sinus that you tend to enter. So that also gives you that this area, this is where the coronary sinus is. Then the shape of the leads entering into the ventricle also gives you an idea of how you are going to look around for the coronary sinus. Then the other thing is that if that patient go into maybe ventricular tachycardia or ventricular fibrillation or any fatal rhythm, you have a lead to be able to take over and do your anti-tachycardia pacing and take over the rhythm at that point. Then the other issue again is that if one of the indication is bradyarrhythmia and the patient go into a systole, you'll be able to take over the rhythm immediately by having that lead there. Then another thing again is that when a patient has complete heart block and the heart rate is low, it's always advisable that don't push your access wires into the IVC. If you push your access wire into the IVC, when the heart contracts, those wires keep having contact with the lower part of the atrium. And if that happens, you can generate a rhythm. And if a rhythm is generated, the patient go into a systole immediately. So for a patient who has a complete heart block, it's always advisable that you should keep your guide wires maybe at the mid atrium. Just keep them around there so that when you don't necessarily generate rhythm to knock out the fragile rhythm that is already existing at that point. So I think these are some of the things that I want us to draw home regards to asystole. And also, as Elvis said, in management of asystole generally, apart from the T's and the H, your CPR is the key thing to management of asystole. It's a non-shockable reading. CPR is the key thing. Like that case he pointed out, 2018, as we noticed it on the reading that this patient is on asystole, immediately he went in for the CPR. So I told him, just continue your CPR, and I will just push in the lead and get it and get this patient pace. So, and that was exactly what happened. As he continued the CPR, that fraction of second, the CPR helps in getting circulation to the brain, and also the coronary circulation also to a segment being sustained by the CPR, and also the renal circulation to the segment being sustained by the CPR, while you try to sort out that reading and convert it to a sinus reading. And that was what we did that very day. Then the other key things here is that when you are also poking around the coronary sinus, maybe you try to locate the coronary sinus with a wire, especially people that have a complete heart block and they have indication for biventricular pacing. Because the AV node is just sharing a border with the coronary sinus. The wire may be touching that AV node, and it may knock out your rhythm, and the patient may also go into more bradycardia or enter into asystole. So these are the things. Those of us who are in the developing countries, you must not have everything that you need to get things done. Yeah, the ideal thing is that when a patient has a complete heart block, or when a patient has any of these symptoms and you want to put a device, you want to put a pacemaker, first of all, put the patient on a temporary pacemaker. Yes, that is the ideal thing. But when you are in an environment where you don't have all that, what can you still do to get a patient well satisfied and also get things running? These are some of the tips that will help you here and there. Thank you.
Fantastic, Dr. Duffy. Thank you. Great insight as always.
That was
Could listen to that all day.
Thank you, sir.
yeah.
Thank you.
So, Dr. Duffy, can you all hear me? My service isn't great right now.
Yes,
clear, mate.
AJ, I can hear you.
Perfect. So one of the things you mentioned, that was a really good example of how you kept the device pacing by using the 2 leads strategy, right? You use the lead you'll use for the right atrium as a temporary pacing wire. That's
Correct.
Brilliant. And I'd always recommend, having some way to keep the pacing going. Things to keep in mind when you are using 2 different pacemakers. So like an external pacemaker or the old device and the new device, if they're not sent asynchronous, then they could be over-sensing, or they could sense a pacing spike that's not capturing and cause inhibition on the other device. So one thing I'll always tell people is, if they have like a temporary wire in, for example, and they're trying to test an atrial lead, I've seen it where the atrial output is high enough that the spike from the atrial pace was inhibiting the ventricular pacing wire. But because the device doesn't know that you're pacing, because they're 2 different independent blind devices, it'll cause inhibition on the old device. So I think asynchronous, and feel free, Elvis, Jared, Dr. Dafe, to chime in here and correct me, but I think asynchronous is your friend in those cases where, you risk a little bit of competitive pacing, or you risk a possible pacing into T. But for a dependent patient, I think it's always better just to capture. So making sure that your device is set asynchronous, possibly both devices. So for a gym change, for example, in a dependent patient, I will have the old device set at, say, 80, 70, 80 beats a minute, depending what their underlying rhythm is. I will have their temporary wire, or their PSA, set to 80, 90, and then I will have the new device 90, 100. The idea being that you always have the final device at the faster rate, so when you connect to it, you're capturing, and you can turn off the old asynchronous device, but always having that backup ability and those asynchronous devices working together.
Very correct, AJ. 100% correct. Thank you. Then there are also some medications that if you have them in your cupboard, you can also try them. Things like isoproterenol, you can try them. Then also before, like this patient that we encountered at Enugu, one of the things we did was that we tried to program the device and brought it down to 30, 35, and notice that the patient does not have any good underlying native rhythm to mash up what we have. So what we did was that before we started that case, AJ, we lowered the output to the lower rate at 40. So the patient was already on the table, so we put it at 40. Then we went in and did all our changes and connections. And once the new pacemaker came in, automatically lower rates at 60. So we move on and fine, we are fantastic. But if you have all this isoproterenol, you can give, and some people also suggest that you can also raise the feet of the patient to increase more output. Some also suggest that you can give atropine to either improve native rhythm or stimulate, improve native rhythm. I don't know whether they actually perfectly work, but if they work, fine. If they don't work, still follow this procedure, these processes which we just described, and I think it will be fine. The aim is to get the patient free from any fractions of asystole. Okay, over to you, Gerard and AJ.
Sorry, I was talking to myself there. I was on mute. No, that's perfect, Doctor. Thank you so much for the input. Really, really good.
Yeah, thank you, sir. Yes, sir. Yes, sir.
Is there any other questions from anyone before we close the session?
Sorry to keep chiming in
Then,
here.
then
Please,
for
if you
our
have another
audience
question,
too,
hop in.
yeah, the
please do, man.
epinephrine, yeah, the epinephrine, we give it, you can give it 1 milligram every 3 to 5 minutes during the CPR. Sometimes while giving it, it may help to generate a rhythm, but the CPR is a key thing that we use in the management.
It's great. Can anyone hear me right now?
Yes, we can hear you.
Yeah, mate, we've got you. We've got you loud and clear.
Oh, perfect. To your point, Dr. Dafe, the previous one you made about dropping down the rhythm. So one thing I would always advise is, reducing the rate, seeing what their underlying rhythm is. And you can do this by actually bringing the rate down slowly, not just setting it, dropping it from like 70 to 30. Correct. It will actually encourage intrinsic to break across as you slowly reduce the rate. If you can find a solid underlying rhythm, as Dr. Dafe was talking about, around 30 or 40, program the device at a backup rate of 30 just in case, and that will make your changeover that much easier, because sometimes patients will have a large pause if you immediately cut their rate off, and you don't want that pause when you're trying to concentrate and connect a new lead. It's very stressful. If you slowly bring it down, if you let the rhythm come across, then you can have a nice leisurely changeover to the device, disconnect the old device, connect the new device, bring the rate up, and no one has to have any kind of clenched fist moments. So I would always recommend finding an underlying if they have one and allowing it to happen if the patient tolerates it, obviously.
Yes, sir.
That's perfect, mate. Good tips. Any other questions from the group? Sounds like a silence to me. So In that case, we'll just a big thank you to Elvis again. Great talk, mate. Great discussions, and
Thank you
appreciate
very
it.
much, Elvis.
Yeah,
Thank you,
that was
Doctor. Thank you, Jara. Thank you, AJ.
Thank you,
Thanks,
Dr.
Sharon. Thanks,
Davian.
Great discussion.
Thank you,
Yeah.
everyone.
Thanks for everyone's
Yes,
input,
sir.
and
Thank
enjoy the
you.
rest of your
Elvis,
evening.
go and rest. So go and rest. Sleep, 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 sleep. No work today. Sleep.
He's a lucky boy. And we'll
Sleep, my brother, because the work was too hectic on us. Just sleep, sleep, sleep. Don't do anything now. Sleep.
Thank you,
Yeah,
everybody.
thank you so much.
Get
Have
some
a
sleep,
great,
Elvis.
a very great weekend.
likewise, and we'll catch up in 2 weeks' time.
Yes, and also we are advertising the Port Harcourt Cardiovascular Symposium. The program will be out before ending of this week. So AJ and Jared, there's a topic I think for two of you.
Yes.
On programming and interrogation. So I will send it to you.
Okay.
Yeah. So we are working on the final phase of it. So I will communicate with you this week.
Not a problem, sir.
Jared. Yeah.
Sounds great. Look forward to helping.
Yeah. And there will also be a Zoom section of it for those of us who cannot travel down to Port Harcourt. You can join from Zoom. It will be a whole day, program, 8 a.m. to 5 or 6 p.m. in the evening.
Excellent, Doctor.
Looking forward
Thank you,
to it.
sir. Yeah, thank you,
you.
sir. Yes, sir.